Hello everyone, just give me a few seconds to get started. I am Dr. Amrit Nasta, a bariatric surgeon from Mumbai. Today is my second YouTube class. It is image based questions in surgery part 2. Just give me a few seconds as everyone signs in and then we will begin for the day. Just give me a few seconds as everyone signs in and then we will begin for the day. If I am loud and clear, please give me a hi. All those who have logged in, who are attending my class today. If I am loud and clear, please give me a hi. All those who have logged in, who are attending my class today. If I am loud and clear, please give me a hi. I will just wait for a few more seconds and then I will begin my class of today. Today's is an interesting class. I expect a good amount of interaction with you in continuation with my previous class on image based questions in surgery. So I hope I get the same interaction. Hi Vinay Kumar. If I am loud and clear, please wave out to me so I know I can begin. Okay, I will begin now with my first image based question. So, identify this imaging technique. Is it an A mode of ultrasound? Is it a linear EUS, a radial EUS, or a lower limb venous Doppler? Yes, please go on. These kind of images are all there in Love and Melee, and since they are asking you a lot of image based questions, I'm trying to cover the important topics. This close to your exam, there are a lot of important topics, a lot of important imaging. This is one of them. Yes, go on. Anyone wishes to answer? Venisha says radial, Soumya says C, Manish says C, Saravanan says C, Sumit says C. Alright, okay, a lot of answers. Anyone with a different answer? Indrani, Vinay Kumar, they are all saying radial EUS. Yes, you guys are right. This is a radial EOS. So remember, any image which is a gray image like this is going to be an ultrasound. Now, if this what you see in the center, which looks circular, that is the tip of the endoscope. Alright, where the ultrasound probe is attached. Now there are two kinds of endoscopic ultrasounds. One is radial. Now in radial you will see the whole circumference of whatever luminal structure you are seeing, and you can see superficial mucosa, submucosa, muscularis and serosa. A linear EUS will look like this. Okay, so this is the edge of the endoscope. So you can only see a part of the circumference. Alright, you can only see a part of the circumference of whatever luminal structure you are seeing. So partial circumference will be linear EUS, layer by layer. But the advantage of a linear EUS is it has a side channel which allows you to take a biopsy. So the side channel allows you to take a biopsy. The A mode, which I asked, A mode of ultrasound, that is the amplitude mode. Remember, ultrasound has A mode, B mode, M mode. A mode is the amplitude mode, which is a single dimension. Okay, it's not two dimensional like this, it's a single dimension, and it is mainly used in ophthalmology for length of the eyeball. Alright, so that is A mode. B mode is brightness mode. That is a commonly used ultrasound mode. Okay, so that's about this image. Now an interesting question. Nowadays they are asking you a lot of knots and sutures. Identify this knot. Is it a reef knot, an Aberdeen knot, a Roder's knot, or an intracorporeal knot? Fire away. Let's see what you guys think about this. It's a little tricky question. Which type of knot is this? Yes, go on. Look at the configuration. Indrani says A, reef knot. Okay. Is this how a reef knot is? Manish says intracorporeal. Neelu also says reef. Kevin says intracorporeal. I am happy when I get mixed responses. Soumya says intracorporeal. Asha says A, reef knot. Okay, Vinay Kumar says Aberdeen. Wow, I am getting all the answers. Lalit says reef. Venisha says Aberdeen. Go on. Anyone for roder? No one is giving roder as an answer. Every other option is taken. Yeah. They will ask you a knot like this. Every time they are not going to ask you square knot or granny knot. They are going to take it a step further. In the in the November aims this year, they had asked you about knotting. Yes, anyone with a different answer? Unfortunately, all of you are wrong. This type of a knot is a roder's knot. Now, what is a roder's knot? A roder's knot, this kind of a knot is used in laparoscopic surgery. Okay, and it's an extracorporeal knot. By extracorporeal, I mean the knot is taken outside the body and it is passed inside the body via the laparoscopic trocar. Alright, so it is an extracorporeal knot used in laparoscopy. So what happens is the knot is configured like this. So there is a loop, and then look at this. This part is the important part. This part is called the snake or the tail. Okay, this is the snake or the tail. So what it allows is this knot to be pushed inside. Okay, this knot gets pushed inside. It's a type of extracorporeal knot. This knot is used for suturing the appendicectomy stump in laparoscopic appendicectomy. Remember this? Roder's knot is used. It is an extracorporeal knot in laparoscopic appendicectomy. So you make the knot outside and pass inside. Yes, Somi, I will explain all the knots. Don't worry. This knot, which is the square knot, okay, the square knot is also called the reef knot, or a lot of you were calling this as reef, where the square knot is the reef knot. They are both the same. Square knot is the ideal knot. How do you identify the square knot? Is look at these prongs. All right, so look at this part. Now both these ends are on top, and here both these ends are going from inside. So a configuration where on one side both ends are going out and on the other side both ends are in is a square knot. Okay, that is a square knot. A granny knot is one is going in, one is out, one is in, one is out. So there is an alternation. So if there is an alternation, then it is a granny knot. A granny knot is not an ideal knot. And this is the surgeon's knot. This is the final configuration of a surgeon's knot. Now remember, a surgeon's knot is also a square knot, only that it has more loops. Okay, it has more loops. So this is the kind of knot which you may have made in your internship when you are doing CLW suturing with a needle holder. So what you do is first you take two throws and tie, then you take one throw and tie. So this four loops are coming from the two throws, and this one is coming from the single throw. So this is the surgeon's knot, which is again an ideal knot. The last option which I said, that was the Aberdeen knot. Now remember, this Aberdeen knot is a very peculiar knot which is used in suturing. So when you see this kind of a suturing, a loop is made at the end of the suture and it is pulled from inside. Okay, that is how it looks, where a loop is made and a part of the suture is pulled from inside. So what will happen is this knot gets buried. Okay, the Aberdeen knot is a knot which can get buried. That is what this is. Remember this configuration where one loop is being pulled from the other loop created during suturing. That is Aberdeen's knot. Intracorporeal knot simply means knotting in laparoscopic surgery inside. Intra means inside, corporeal means body. So here what the surgeon is doing is using laparoscopic instruments. He is suturing inside. Yes, Aberdeen is kind of continuous locking. Kevin, you could say that. It is kind of continuous locking, but in Aberdeen the knot can get buried. Okay, so it can be the last knot in a suture. Please make a note of all these knots. I expect this Roder's knot to be asked. It is an extracorporeal knot. Extracorporeal means tied from outside in laparoscopic surgery. Okay? Interesting. Identify this imaging given in the picture. Okay? Is it an ERCP image, an MRCP image, a HIDA image, or a T-tube cholangiogram image? Yes, go on. Is it an ERCP, MRCP, HIDA, or a T-tube cholangiogram? There are some hints in the image which will help you identify what image this is. Yes, what is this image? Madhu says T-tube, Kevin Indrani Venisha says T-tube, Dr. Rahul Sharma says ERCP. What is this structure going here? Andro says MRCP, Manish says A, Soumya says D, Prashant T-tube, Niranjan, Sumita, Vinay all are saying T-tube. Okay, Andro has changed his answer. Now he is also saying T-tube. Yes, you are right. This is a T-tube cholangiogram. Absolutely right. Now, why is this a cholangiogram? Obviously, you know, these are the ducts, the right and the left hepatic duct. This is the common hepatic duct, common bile duct. Somewhere it is going into the duodenum. This is probably the contrast in the duodenum. Now, there are many cholangiograms. This could as well have been an intra-op cholangiogram, but what you need to see is this limb. This is the limb of a T-tube. Alright, this is the radio-opaque limb of a T-tube catheter, or probably the contrast going through the T-tube. Alright, a very important image. Remember the T-tube cholangiogram. A cholangiogram in this case is basically an X-ray. So you will see these bones and the ribs. That is how this cholangiogram is configured. I will show you the other grams. This is an ERCP or endoscopic retrograde cholangiopancreaticogram. Now what's happening here is you can see the biliary tree. You can also see contrast in the pancreas. So this is in the pancreatic duct, and obviously you can see the endoscope. So this is the tip to identify an ERCP: endoscope, biliary tree, and pancreatic duct. If you see over here, you could not see the pancreatic duct, which would have been going somewhere over here. Alright, so this is an ERCP cholangiogram. This is an MRCP. Remember, in an MRCP or an MRI of any kind, you do not see the bones. You see the soft tissues. Like in this, you can see the vertebrae. Over here, you see there are no vertebrae. In MRI, the bones are not highlighted, unlike a CT or an X-ray. So any image where you don't see the bone but you see everything else is probably an MR image. So this is an MR cholangiopancreaticogram. Okay, this is probably the contrast going in the gallbladder. That is the tip to identify any kind of an MR image. And this is the HIDA scan. So this is the liver. A HIDA scan is a radionucleotide scan. You see hot, warm, cold areas. Now HIDA is the isotope which is excreted in bile by the liver. So it has a liver uptake. This is why you can see the liver, and this is the excretion of the HIDA scan. Alright, so a HIDA scan is basically a functional study of the liver and the biliary tree. Alright, these are the few tips and tricks that you need to know so that you are able to identify these imagings easily. Now this is a tricky question, please take some time. Don't jump onto this. This is a recent advance. This has never been asked. Okay. False statement about suture material given below. False statement. Alright. Knotting is not required. Can be used for suturing rectus sheath. Longer length required. Available in absorbable and non-absorbable forms. Okay, please look at the suture material correctly. It is not the common suture material. Okay, it's a newly used suture material which has been used maybe in the last 10-15 years, and no question has been asked on this yet. So what do you think is the answer? What is this suture material? I can tell you, this is the needle and this is the suture. Manish says C. Okay. Anyone else with a different view? Look at these things projecting from this. It is not a normal suture material. Madhu Venisha say D. Okay. Neelu says C. Anyone for knotting is not required. Isn't that unusual for a suture to have no knotting? Venisha says proline. What are these things jutting out from the proline? Soumya says A. Knotting is not required. Okay. Vinay Kumar says C. Sumita says C. Indrani says D. Available, absorbable. Niranjan Gangur says D. Okay. Go on. What are these things that are jutting out? Micral barbed. Okay. Anyone with a different view? Okay. So let me give you the answer. So first of all, okay, Prashant says A. First of all, this is a barbed suture. That is right. It is not the traditional suture. It is a barbed suture. It's not vicral barbed. So it is a barbed suture, it is self-locking, right? So because it is self-locking, knotting is not required. Yes, it can be used for suturing rectus sheath. It is available in absorbable and non-absorbable. And obviously, if you are not knotting, so that length that is wasted in knotting will not be required. So actually, you need shorter length than a normal suture material. So it's not longer length, it is shorter length. Please look at the suture very clearly. There are these things jutting out which prevent the suture from falling back. So once you take a bite through the tissue, the suture remains. It doesn't go out because of these barbs. Okay. Barb suture has not been asked before. I expect, since they are asking a lot about knotting and suturing, this can come. This is a barbed suture. Alright. And a little bit about length of suture material. There is a rule called as Jenkins rule. The Jenkins rule states that when you are closing a laparotomy wound, the length of the suture to the length of the incision should be 4:1. Please remember this MCQ and Jenkins rule. Length of suture to length of incision should be 4:1. Alright. So a little bit about the other sutures, which is what I wanted to teach you today. just remember the important points. There are basically two categories: monofilament and braided or polyfilament. This is not braided, okay? This is barbed. Barbed means projectile, so there are projections coming from it. This is what is a braided suture, alright, where different monofilament sutures are woven together. That is braided or polyfilament. This is monofilament, this is straight. Now, the important monofilament sutures you need to know are PDS. Okay, PDS is polydioxanone, proline or polypropylene, and ethylene or nylon. These are the commonly used monofilament sutures. The thing about monofilament suture is they have good memory. Remember, in sutures, good memory is a bad thing. Okay, good memory is a bad thing. So what it means is, if I give it a certain shape, the shape remains. So it makes knotting difficult. Okay, the suture remembers the shape. So good memory is a bad thing. That is the problem with monofilament sutures. Other MCQ is, because they are monofilament, they do not allow a lot of bacterial overgrowth, so infections are less. So they are preferred for vascular anastomosis. Remember these important points of monofilament sutures. Braided sutures, on the other hand, are your catgut or chromic catgut. Remember, catgut is not from cat, it is from sheep or cows. Collagen from them, or silk, or what we commonly use is mer silk, which is black in color, or vicryl. Vicryl is this polyglycolic acid, that is vicryl. Remember, braided sutures have poor memory, which means they do not take the shape in which they were left, which is a good thing. Poor memory is useful and fewer knots are required. So because they are polyfilament or braided, once the knot is made, the knot stays. So you don't need too many knots. Whereas in a monofilament, you need at least 7 knots. Okay, for it to be called as a secure suture. So at least 7 knots. Alright. Now this again, I expect this to come. Identify this type of needle. Is it a cutting needle, reverse cutting needle, taper cutting needle, or taper point needle? Please identify this type of needle. Yes, go on. Look at the tip, look at the shape. I have given you some hint in this little picture. Identify this type of needle. Okay. Abhilash, Kevin say reverse cutting. Interesting. Vinay Kumar says taper. Indrani says taper point. Okay. Rumi Bala says reverse. Manish Soumya say taper point. Okay. Hate, Asha, they are all going for taper point. Punaranam says reverse cutting. Madhu says reverse cutting. Okay, more reverse cutting from Niranjan also. Look at the cross section. Look at the sharp edge, and that gives you the answer. Yes, Dr. Meghna also says reverse cutting. Deepan Rai says taper cut. If there is a question in which the audience is giving different answers and not everyone is getting the correct answer, that means the question has a high discriminating value. A question like this I can see is having a high discriminating value, which is why you need to get this right, because these are the kind of questions which will give you an edge. Well, the answer is reverse cutting. Some of you got this right. The answer is reverse cutting. So let me give you a very short and simple way of identifying the type of needle. Now remember, first thing that you see, don't look at the tip. The first thing that you should see is not the tip. The first thing that you should see is the cross sectional area. That is, when you cut the needle, how does it look in cross section? If the cross section is triangle, if the cross section is triangle, it is a cutting needle. Okay, if the cross section is triangle, it is a cutting needle. Now Between the cutting needles, there are two. One is the normal or the curve cutting, other is the reverse cutting. Now remember, in a normal cutting, the cutting edge is inside. So this is the cutting edge which is inside. So if you see the cross section, the triangle looks like this, where the cutting edge is on top. That is your curve cutting needle. A reverse cutting needle will be the opposite. A reverse cutting needle will be triangle, but the cutting will be on the inferior surface or the outer surface. So if you see here, it will be an inverted triangle, thereby a reverse cutting needle. Tapering needles are cylindrical or circular. Okay. Tapering needles are cylindrical or circular. The rest you can make out from this diagram. The rest is plain and simple. Alright. Remember, the commonly used needle on tough structures is the reverse cutting needle. So if I am closing the rectus sheath, if I am closing the tendons, if I am closing the skin, I will use reverse cutting. If I am suturing hollow viscera, okay, like bowel or vessels which don't want to be traumatized too much, I will use these tapering needles, alright, which are round, alright, like blunt taper point, okay. These kind of needles will be used for vascular anastomosis or bowel anastomosis because they cause less trauma. Now this is one of my favorite questions. Identify this procedure. Please look at the procedure carefully before you commit to an answer. There is a trick in the question. It's not a very straightforward procedure. Take your time and answer. Identify this procedure. Is it a Billroth 1, Billroth 2, Roux Y, or a mini gastric bypass? Okay, Prashant, Gitanjali, Kevin, Dr. Ish are all saying Billroth 2. Okay. Sachin is saying Roux Y. Manish is saying Roux Y. Harsha, Indrani are saying D. Wow. B, C, D. All the options have been taken. Dr. Ish, Soumya are all saying C. Neelu is saying C. Meghna is saying mini gastric bypass. Okay. Lot of people giving C. Lot of people initially gave B. Few people gave D. Anybody for Billroth 1? This is not Billroth 1. There is a trick. Please identify the trick. Romi Bala is saying Roux Y. Deepan is saying Billroth 2. Rahul is also saying Roux Y. Nobody for A? Billroth 1. Venisha is saying question mark D. Heath is saying C. Okay. Interesting. This is a very important procedure. Most of you have fallen for the trap. Taibur is saying mini bypass. Okay. Well, this, first of all, look at this. This is the rest of the stomach that is inside. In any Billroth procedure, the Billroth procedures are done for gastric or duodenal ulcers, alright, and they involve resection of the antrum. The first part of a Billroth procedure is antrectomy because antrum is the acid secreting part. If the antrum is inside, means it is intact, so Billroth 1 and 2 are out. Obviously, by elimination, you could have eliminated Billroth because the entire stomach is there inside. No stomach has been taken out. Now the doubt was between Roux Y and Mini. Does this look like a Y? I don't think so. This is not looking like a Y. So by elimination, you could have given the answer even if you didn't know that it's a mini gastric bypass. So this is a mini gastric bypass. Now let me tell you what are the others. What is a Billroth one? You remove the antrum and you do a GD, gastroduodenostomy, which you can see here. This is duodenum, this is stomach. So that is Billroth 1. Billroth 2, remove the antrum and do a gastrojejunostomy, which is a loop gastrojejunostomy. I agree this looks similar. no doubt, but what you needed to see was the antrum was still there inside. Here the antrum is resected. That is why you do a Billrod 2 to remove the acid secreting antrum. So that is Billrod 2. Roux Y, remember, has two anastomosis. One is the gastrojejunostomy. So this is the small stomach. This is the jejunum. So this is gastrojejunostomy. And lower down is jejunostomy, which is why it looks like a Y. Okay, which is why it looks like a Y. That's how the Y configuration happens. So this is a Roux Y gastrojejunostomy. This is a mini gastric bypass. It is a type of bariatric procedure. Alright, which is why I put this question. It's also called one anastomosis gastric bypass. So remember, if the entire stomach is there, which is partitioned, and there is a loop gastrojejunostomy, then it's a one anastomosis gastric bypass, also called as mini gastric bypass. So he's saying Billrod 2 side to side done or not, it doesn't matter. Obviously, the jejunum will be side, the stomach can be end or the stomach can be side. So the stomach part is not important. Jejunum has to be side because it's a loop. Alright, Mohan, I hope I have clarified that. Very important question, very important procedure. Identify this procedure. Is it stapled hemorrhoidopexy? Is it star, PATME or VAAFT? This I am telling you in my whole today's class is the most important image. What is this procedure? Please focus. This is there in Bailey and Love. Not the same image, but a similar image. Indrani jumps to stapled hemorrhoidopexy. Mohan Babu says VAAFT. Madhu says A. Sunanda says D. Asha says A. Gitanjali says A. Okay. This is stapled hemorrhoidopexy. Okay. Everybody is saying A. Harsha says TATME. Okay. Someone with a different answer. Anyone for star? Do you anybody knows what is star? Soumya says video assisted or WAF. Okay. Manish says TATME. Punaram says stapled hemorrhoidopexy. Nobody for star? Anybody? Kevin says waft. Madhu Sekar says okay. Sachin, thank you. Someone said star at the end. Sachin is saying star. Okay, you guys need to relax a bit. Almost all of you are wrong. Only a few of you got it right. This is a TATME. Ish, I will give you all the full forms. Don't worry. But trust me, these are how the options will come. So this is a TATME. TA is transanal, which means you are going through the anus. TME is, you must have heard of TME, total mesorectal excision. Total mesorectal excision is the treatment for rectal cancer, where apart from removing the rectum, you are removing the entire mesorectum. That is the oncosurgical principle of rectal cancers. Now, why is this TATME transanal? Because you are doing through the anus. This is an instrument through which you are putting a camera and some minimal access surgical instruments, and look at this arrow. What is this arrow showing? Arrow is showing you go in this plane which is behind the rectum and remove all of this part which is the mesorectum. So if you see any perianal procedure with a device like this with a camera and some laparoscopic instruments where you are removing the mesorectum apart from the cancer, obviously you remove the cancer, that is TATME. I want you to open Bailey and Love last edition and look at the image. It is similar. Obviously, I can't use the same image for copyright, but the image is similar. This is TATME done for lower rectal cancers of stage T1 and T2. Okay, nowadays they are avoiding anterior resection or APR and preferring TATME for lower rectal cancers of an early grade. I will tell you the other procedures also. A stapled hemorrhoidopexy is like this, and this is done with a circular stapler. In my previous class on YouTube, if you have seen it, I had shown you what a circular stapler looks like. This is the anvil of the circular stapler, this is the stapling gun, and these are the hemorrhoids which will be stapled. Alright, that is a stapled hemorrhoidopexy. A star. A star is also called as stapled transanal rectal resection, which is similar to this. That's why I've not taken the image. The only difference is in a star, you need two staplers. In hemorrhoidopexy, you need only one stapler. But appearance wise, both look the same. Remember that STAR is done for a disease called as obstructive defecation syndrome or rectorectal intussusception or internal rectal prolapse. They all mean the same. STAR is staple transanal resection of rectum. Alright, is it down to up? What is down to up? I am not understanding Sachin your question. And WAFT or video assisted anal fistula treatment. Well, this is not video assisted. In video assisted anal fistula, what you are doing is passing the laparoscopic probe inside the fistula tract. Okay, so the image of WAFT, the laparoscopic probe will be going inside the fistula, not inside the anus. Okay, so under a videoscopic image, you go inside the fistulous tract and you treat the tract. That is what is VAAFT. I don't think they will ask you VAAFT. I think what you need to know is this TATME. Alright, and the last couple of questions for today. Identify this investigation. Okay, this is there in Billion Love. Just identify this investigation. 24-hour pH study, esophageal manometry, trans-esophageal echo, or virtual esophagoscopy. Alright, identify this investigation. There are a lot of hints in the picture itself. Soumya says 24-hour pH study, very good. Kevin says B, again 24-hour pH. Indrani Kaushal say B. Madhu says B. A lot of people are saying B. Yes, yes, yes. All of you who are saying B are absolutely right. What you could see here, there is some written matter. High amplitude contractions, absence peristalsis. No, Rahul, this is not 24-hour pH. You are seeing amplitude of contractions. So this is obviously a manometry. Okay, or an esophageal manometry. Remember, any image like this where you are getting pressure readings, if you read this carefully, these are all pressure readings. Red means high pressure. Alright, this is an esophageal manometry. So what you need to know is in esophageal manometry, a catheter is put from the nose into the esophagus and upper stomach, and pressure recordings are taken on a computer. Alright, at different parts of the esophagus. So different zones are showing different pressure readings. This is the point where the person was made to drink something. So there is a swallow and the pressure readings are taken in the esophagus and the stomach. Now this implies high pressure in a certain area. Alright, they will not ask you to identify the disease, they will just ask you to identify the investigation. A 24-hour pH study, which some of you answered, looks like this. Okay, it's again a catheter is put from the nose into the esophagus, but what is done is whenever the person feels reflux symptoms, he presses a button and the acid levels in the esophagus are marked. So if you see here, this is pH and this is the chart of acidity in the esophagus. So if you see pH and acid levels, it is 24-hour pH study, which is the investigation of choice or gold standard for GERD. Esophageal manometry is gold standard for motility disorders like eclasia. And another question I asked you was a virtual scopy. Now, any virtual scopy, esophagoscopy, gastroscopy, colonoscopy, it's nothing but a reconstructed image of a CT scan. Okay, any virtual scopy is a 3D reconstruction using a CT scan. Just remember this part about any virtual image, like a virtual scopy. This is the last question. This is the last image which I have put on the premise of my previous class where some people wanted to know about a certain machine. So what is this machine? What is this procedure? Is it PCNL, ESWL, RIRS or pushband? Okay, fire away. What is this procedure this patient is undergoing? This I only put because someone asked me this question the last time. PCNL, ESWL, PCNL, Kevin is saying PCNL, ESWL, Kevin, Kaushal, Niranjan are all for ESWL. Anybody with a different answer? Indrani is saying push bang. Okay, Vinay Kumar says B. Yes, most of you are right. This is ESWL or extracorporeal shock wave lithotripsy, which is done for renal calculi. Simply put, this is the ultrasonic machine which will focus high intensity sound waves, focus them on the stone, and the stone will be broken. So you see there are no cuts. It is an ultrasonic procedure where the stones are fragmented using ultrasonic waves. Extracorporeal means from outside the body. PCNL is a proper surgical procedure where a tube is put percutaneously, it's percutaneous nephrolithotripsy, alright, which is put from the skin at the renal angle into the renal pelvis, and the stones are broken down and removed. Kaushal Kishore is asking up to what size ESWL is not done, or the indications for ESWL are stones up to size 1.5 centimeters. Stones should be soft, not hard stones like cystine, and the stones should not be in the lower calyx. If they are in the lower calyx, after you break them down, they will not get drained, right? Because the lower calyx does not directly drain into the pelvis. So those are the contraindications for ESWL: hard stones, stone more than 1.5, and lower calyxal stones. RIRS is retrograde intrarenal scopy. It is a way of doing endoscopy into the ureter and the pelvis to remove the stones, something new. Push bang is nothing but when I do ureteroscopy and if there is a stone in the ureter, I push it up into the pelvis and then I remove it by either PCNL or ESWL. That is what is push bang. So push bang simply means pushing a ureteric stone into the pelvis up and then taking care of it by some technique. Alright, that's it for today. Hope you liked today's class. If you are happy, please like my class today. If you are not happy, please do not dislike it. This is my referral code for PCNL any stone. Okay, PCNL does not have any size limit. PCNL can be done where you don't do ESWL or even otherwise. Okay, PCNL is like the all-time treatment for renal stones. Okay, but it's a surgery. So I hope you liked the class. I hope it was useful. Merry Christmas and Happy New Year. I teach on the Unacademy Plus platform. My currently ongoing course is on trauma, GI, HPV, rapid revision. If you use my code, you will get a discount. I will also be taking another free class very soon, which will again be a rapid revision class. Alright, make sure you like today's class and thank you for joining.